We've been working with NHS North West for a few years now, and they've already produced two really successful timelines showcasing the involvement of BME staff within the NHS since the NHS started, and also more recently the involvement of lesbian, gay, bisexual and transgender people within the NHS and the influence they've had in healthcare in general. So early last year some discussion started with us and a couple of other disabled people's organisations about doing a similar timeline around disabled people's rights and the history of the disabled people's movement and how disabled people have interacted with healthcare, which has, you know, in the past been quite problematic, and also looking at the current challenges that disabled people still face in accessing healthcare services and influencing change.
I think all of us have had good experiences of the NHS, even though we may also have problems, and particularly where you're meeting with individuals in the service that you meet regularly, perhaps because you have regular appointments and so on, who understand what your specific requirements are as a disabled person. And they can take into account, you know, not only the particular medical condition or procedure that you have to be there for, but also what your information requirements are, your access requirements, and so on. There are three issues that the NHS need to consider and have improved on. I think the buildings are more accessible than they used to be, but there are still issues for some disabled people because designers are not consulting with groups like us on making sure that all disabled people have independent access to everything, for example, information, seating, and where services are placed within the building. I think the procedures that they use are not always accessible, but again, things are improving a little bit. And again, the way people communicate with disabled people, that has improved, but perhaps it's improved more in the hospital sector, where there's been a lot more training and work done than perhaps in GP surgeries, dentists, community-based services and so on. So I suppose that's a mixed message, really. Some things are a lot better and are very positive, but there's a lot to do.
Well, I think what's really important is that all NHS staff are trained in what we call the social model of disability, and that sees disability as a social problem and not a problem that the individual has. So the thing that disables us is inaccessible buildings, is the way in which curbs are set up and things like that, and people's negative assumptions of disability. It's the disabled person hasn't got the problem. And if you work with disabled people to find out what their problems are, then the solutions you offer them will be closer to what they need. It's important to do things with people rather than to them. I was born prematurely with cerebral palsy, and I was given a 20% chance of living. So without the intervention of the surgeon and NHS staff, I wouldn't be here today. So that's extremely positive.
There's always going to be good and bad sides to the whole business, and generally the feedback we get is very positive. My own experiences with the NHS, having a spinal cord injury, is one just completely positive. You know, I was injured 40 years ago, and throughout that 40 years, I can't make any kind of complaint against them. The service has been exemplary, you know, particularly at the spinal unit at Southport.
As a service user of the NHS for quite some time, the most positive experience I had was with the midwifery service. I've had 3 children, And right from the outset, as a young 21-year-old, I was treated equally by the midwives, and that is something that stays with me today.
The NHS, when they treat the service user as a patient and give the respect and dignity, that to me is best practice. And I can think of many occasions when they have. They do get it wrong. I can imagine the pressure on the NHS is enormous. The biggest insult or slight to me is where I'm not given the dignity, or I perceive I'm not given the dignity, that someone else whose average height, I'm a dwarf, I'm only 1.38 metres tall, where I perceive I'm not taken seriously because I'm different to others. Assumptions that medical professionals make are often incorrect. And secondly, it's where they feel because you haven't got a white coat on or because you're disabled, they come over in a position of power and talk to you differently. And that really irritates me. My wife, who is far more polite than me, will accept it. I don't.
Speech therapy services are virtually non-existent for people who use communication aids. Just because I don't speak doesn't mean I have nothing to say. Not enough speech and language therapists who think outside of the box. They seem to be restricted and limited in what they can offer individuals. The service does not feel very personal. Sometimes you feel like another number. Speech-language therapist courses are very clinical. This needs a change. Communication is multifaceted, and whatever works for a person should be supported, not criticized. Too many docs feel autism is a behavior problem that you can do much about. However, I think it's a biomedical problem. There seems to be great negativity about dietary sultines such as gluten-free food within the NHS. No funding available for food therapy services such as Matthew's Friends Clinic and other such organizations. Conventional testing not good enough. Alternatives need to be considered to get a bigger picture. Taking blood is difficult for me, but essential, so more help and support for this would be great. Sensory difficulty. No sensory integration therapy for adults. Children now able to access an occupational therapist for sensory integration, but adults cannot have access to these services. This needs to change.
The type of osteoarthritis that I have started when I was a child, but was never diagnosed until I was 29. Social services are much further down this track than the NHS. But at present I don't receive any ongoing treatment for my health conditions apart from pills. Although some programs are available, I can't go on them because I've got more than one health condition. And it seems odd that the more health problems that you have, the less help sometimes you get. And if I weren't working, I wouldn't be able to afford to pay for the treatment that I do pay for myself privately. So I would like to see much more progress towards the personalisation of health services and the introduction of personal health budgets generally.
I've not had an operation for about 4 years, so I was took off the list. So I had to go back through my GP to get referred back to the NHS so that they could find a plastic surgeon, because my plastic surgeon that I was under has retired now. So I had to go through a little bit of trouble, and a little bit of waiting for him to find me a plastic surgeon who's willing to take me on and stuff. I used to go to Bouval when I was a kid, children's hospital. I had really good experience with the nurses in there. They looked after me quite a lot because I was down as a regular, as you would call it really, because I was there that much, and I got to know quite a lot of them really well. so they did look after me. When I turned 16, I got transferred to Wythenshawe Hospital under the burns unit on there.
12 years ago, I was diagnosed with throat cancer, and what I actually experienced there was not pleasant, especially when sort of going down to the operating theatre. I was asked by the anaesthetist if I would actually want resuscitating if there was a problem. And I said, well, of course I do. I said, but do you ask all your patients that question? And she responded by saying, no, but given your disability. And I found that extremely frustrating.
If the NHS was more understanding about dystonia and other disabilities, then they may possibly be able to do improvements if they knew about the people with different disabilities.
I think I'd like to give a special mention to the Manchester Royal Infirmary, because I have had a good experience of their care, and other friends of mine have had the same experience. Nursing staff really good, consultants, they know what they're doing, blood tests, hormone checks, all of that is really, really good. You can't fault the care from there, so thank you very much.
For myself, because I have an invisible disability, I don't mind saying it's dyslexia. It's not seen, so people don't maybe see the support is necessary for people like myself. So I think we need to really help all sorts of people with disabilities and keep them and recruit them in the NHS, because it's a very good career and a very good organisation when you get that support. If we're helping people with conditions and impairments coming into hospitals, GP surgeries, any front line, we as an NHS trust or organisation have got to help our people to recruit and to retain them. So we have to be positive and be forward thinking, and let's do it.
I feel the NHS should really talk to managers more to help managers understand the feelings and the problems that disabled staff go through. I think they need to talk to the disabled member of staff more, find out exactly what their problems are and how they can best help them in their workplace. It was a chair issue again, and my physical problems I was having with my disability, and my manager said that he thought my problems were all from home, not from work, and I probably didn't have the correct sort of bed, and somebody should go to my house and have a look at the inadequacy of the bed I slept in.
Yeah, I've got two experiences that I'd like to share with you. One was around my recruitment into the NHS, which was very interesting and actually makes a few eyebrows raised when I mention it. The day before I started in the NHS, I was coming out of the occupational health department, and my boss at the time actually bumped into me and said, "Dave, it's nice to see you. We had a meeting about you this morning." And I said, well, okay, that would have been nice if you'd have invited me. He said, no, it was something internal. One of the questions that was raised was, how many days off sick do you think you'll have off? And I said, well, I don't know. I've not worked for 7 years. And I asked him the question, how many did he have off? And he responded by saying, I'm not sick. And I said, well, neither am I. And it was quite interesting that sort of I felt quite threatened for about the first 2 or 3 years that I had to be in work, even with cold, flu, and other sort of illnesses. To improve the experience of people with disabilities, people who are service users in our mental health trust, we need to employ more people who've got direct experience themselves. And that's something we're certainly doing now through our Positive Action and Employment Scheme, where we're encouraging and supporting people through the recruitment stage. In fact, one innovative way was only last week we decided we're going to recruit more people into our bank. This is our bank staff around nursing auxiliaries, where it gives people that flexibility to come into the system, and if they do actually sort of fall ill, they can actually sort of back off because it's not a permanent contract that they've got. And then hopefully, as the time goes on and they find themselves more able and they're going through the recovery stage, they can then apply for open employment with the trust.
I think The working conditions for disabled staff in the NHS is a challenge both for the NHS and the people who work there. I think a lot of the issues are around people who acquire the disabilities while doing work, because they don't want to use valuable staff. But by the same token, disability can be seen as a very negative thing to happen to you, and people need time to adjust. I think the NHS is so big, and whilst individuals are very supportive, as a whole, it needs to be more holistic towards its staff.
Some staff may feel anxious about disclosing a disability, perhaps perceiving a risk to their job situation for that, whereas in fact the opposite may be said to be true, that employers have responsibilities for providing appropriately for the needs of their disabled staff.
My disability is I'm dyslexic. I find managers, more so than colleagues, a lack of understanding about my own disability. But I've seen within the NHS people with various disabilities get treated really unfairly. And I think it's a lack of understanding, a lack of awareness.
Where the NHS gets it right is where they've involved disabled people in co-production. My wife and I occasionally do some work for local hospitals and GPs who are training future GPs or registrars who want to become consultants. And we become involved in that training as a real-life case study, not under what we would call the medical model, but more the social side, where registrars would come in and talk to us, ask us a series of questions about how our impairments affect us and how they, as either GPs or consultants, should know and what's important to them. If the NHS continue to do that, then I think disabled people will be treated with more respect and dignity.
Training for NHS staff in epilepsy and how to manage and support it in accident and emergency units is also very important. Without my family or personal assistants present with me at hospital, I would not have confidence in the staff at accident and emergency in meeting my needs.
I have. Recently I've been working with physiotherapists and occupational therapists in order to maintain my independence with equipment, so I can live independently in my own flat. To maintain my own personal independence and dignity is a vital core for me in my lifestyle and my life in general, and without the cooperation of NHS staff I wouldn't have been able to maintain my current level of independence, so it's something I'm very thankful for. People make assumptions about people in wheelchairs. I think it's very important for people to adhere to the principle of speak as to someone who you'd like to be spoken to. So ask the disabled person what they would like, how they would like to be dealt with first, and then you're more likely to meet the needs of that individual in a way that suits them. I think that's really important. You know, don't just assume that every person in a wheelchair or every person with a learning disability is the same. Each individual is different and deserves to be treated with respect and dignity. And I would encourage all staff at all levels to try and do that to the best of their ability.
I think it's always been helpful in the past where there's been consultation groups and regular consultation meetings with disabled people and their organisations. If you have regular consultations, you can identify key issues that disabled people face as patients, as visitors, and as members of staff, which is sometimes forgotten about. And you can set priorities. And I think at a time when we haven't got a lot of money around, it's important for us to work in partnership on trying to move forward on some of these issues.
We were really keen to ensure that disabled people were involved right throughout the process of the development of the timeline. To start with, a steering group was set up of disabled people and disabled people's organisations to sort of oversee the project and work with NHS North West as it evolved. And then lots of meetings have taken place with stakeholders across the region to start with, to look at what should be in it, what its focus should be. It was agreed that it should come from a social model of disability perspective, so looking at barrier removal rather than a more sort of traditional medical perspective, and looking at things like the access. With the film that we're producing today, that's been developed collaboratively as well, and disabled people who've been trained as community reporters have been involved in the development and the interviewing for this. So it's been a very co-produced piece of work.